Okay, so I think now is a good time to start. So good afternoon. Very, very warm welcome to today's webinar from the Integrating Our Mental and Physical Healthcare Systems team. It's the fourth webinar we've done now. And today is all about the work that we did in our CMHTs in SLaM. Just a little bit of background and context. So IMPHS is a program of work that was funded by the Maudsley charity, and we focused on identifying, testing and evaluating physical health interventions that can improve the lives of adults living with serious mental illness. And through this webinar series, what we're really seeking to do is to guide you through some of the individual projects that have been in our portfolio. We've invited clinicians and researchers, project managers, and a lot of the experts by experience that we've worked with and have collaborated with, who've been involved in the work, to share their experience and learning, and also hopefully some ideas for future development of work that you or we may be able to take away. So my name's Ray McGrath, and I am a mental health nurse, and I've been the lead nurse for the IMPHS project over the last few years. Over the next hour, I'm just going to guide you through today's webinar, introduce the speakers, and the focus today is on a recent service evaluation we completed, investigating physical healthcare of adults with SMI in adult community mental health teams in the South London Mental Health Trust. So I'm now going to share the agenda slide. Excellent. So we've got various sections here which we'll be going through, different speakers for each of those who I'll introduce. Just wanted to make you aware that we are recording today's session as well, and we'll be sharing the recording following today. The videos will go on the KHP website. We've got 8 links for the other videos that we've previously done. And finally, before I hand over to our first speaker, we want to make this as interactive a session as possible, and we invite you to either raise your hand or add comments to the chat function as we go through the webinar this afternoon. We do have a section at the end for question and answers, which we hope you'll be able to be part of and stay around for. So without further ado, I'm handing over to Helen Kelsall, our Deputy Chief Nurse at South London and Maudsley NHS Foundation Trust, who will give us a bit of a background, or give you a bit of a background and rationale for why we did this work and why it was so important. Thank you, Helen.
Thanks, Ray. Hi, everyone. Thanks for joining today. So the sort of plans, the reason we did this work, we are committed to ensuring that we complete the 6 core assessment interventions for our patients with a diagnosis of serious mental illness that we know have been shown to identify potential early health challenges that can lead on to earlier intervention for this particular patient group. And we were sat in a room one dark December, hypothesizing about why we were experiencing so many challenges around ensuring that our staff and our patients had access and the ability to have these assessments undertaken. And we concluded that in the spirit of our work that we've been doing around staff engagement, that it was a mistake to sit in a darkened room and hypothesize, that we really needed to take an opportunity to go out there and talk again with our staff and our service users, to really try and take an opportunity to understand the expectations of our service users, most importantly, and what they felt was what they thought their view was and what they should receive from us. Because if you think about physical healthcare as a term, it's vast and it covers a million different things. And we wondered if that was a challenge also for our staff, because actually when you say when you use the term, we need to do physical healthcare interventions, it could mean a number of things. So we thought the right thing to do was go out there and talk to them, and the IMPHS team were really keen to support this piece of work and allow us to think about how we could use that to restate our commitment to our service users. And it aligned quite nicely to the time that we were reviewing our strategy, and a commitment to reducing the mortality rate in our patients who have a diagnosis of SMI remains a core part of our strategy. And we recognise that early identification of physical health challenges is critical to that. So it was a real opportunity for our staff and our service users and our carers indeed to talk to people with a degree of impartiality, without any expectation, in an open and warm way, and hopefully then also be part of the journey onwards, because the intention was not simply to gather this data. We're exceptional data gatherers in the NHS, but also to do something meaningful with them. And we have started that work already. So with the core recommendations, we've started the process of a workshop, which is going to happen in March. I'm sure they'll talk more about this in the webinar, but that'll be part of an ongoing journey of really coming together with our frontline clinicians and our patients and our service users to provide the service they should expect, but also to make that provision meaningful. And the other component of this was that we recognise, certainly I speak from a nursing perspective, but that mental health nurse education has relatively limited coverage, if you like, of physical health issues, and therefore there could be some perceived barriers, that there is unknown things and things that people aren't aware of. And we really wanted to use that as an opportunity to really understand what support our staff needed and what potential education programs would be needed. So that was really where this came from, and the IMPHS team have gone on to do a most fantastic piece of work, and the data is really rich, and in some ways it's told us some things that we think we already knew, but actually it's been really helpful to have that confirmed by our clinicians, our patients and our carers. And I think I'm going to leave it there, Ryan.
Thank you, Helen, and thank you for also already starting to touch upon some of the outputs of this work and how it's starting to shape what's happening in the Trust. I'm now going to hand over to Dr. Julie Williams, who was the IMPHS lead researcher, and also Gracie, who is our current project manager, but who really led this piece of work. Over to you guys.
Thank you so much, Ray. Afternoon, everybody. It really is such a pleasure to be here, really, to speak about this work. As Ray and Helen have said already, this is a really important piece of work for us within the IMPHS project, because we really recognise that physical healthcare is something that we need to be understanding more, and we need to be thinking about collectively about what difference it can really make if we understand the need and ways in which we can address it better together for patients living with serious mental illnesses. And what we want to be able to do through this next part of the webinar is really guide you through the methods that we've adopted by working with SLaM, and to look at how we could conduct this service evaluation. And many people that are in the room today have been a part of this work, and the names of which are listed here, of course, people that have been involved, but there's been so many more besides that have helped us be able to look very closely at this topic. So we want to be able to share with you the method and some of the results, but also beyond that, some of the key thinking that we have collated together to think about how this could be relevant for other people beyond our immediate team, and of course beyond SLaM as a trust that we're working closely with through this work. So I'm going to first of all hand over to Julie, and I'll come back in just a bit to share more of the results. Julie, over to you.
Thank you, Gracie. Hi, everybody. Yeah, I'm going to just talk you through the methods for the service evaluation. This first slide, I think, probably won't be a surprise to anyone on this call. We know that people with a diagnosis of severe mental illness are at greater risk of premature death and have higher rates of conditions such as diabetes and cardiovascular disease. And you can see from that graph on the right, you know, what difference there are between people with SMI and the general population. And it's an issue that's been known about for a long time, and something that I think lots of people across the UK and beyond are trying to address. Next slide, please, Gracie. In 2014, the National Institute for Health and Care Excellence, NICE, issued guidance for treatment, which included guidance around physical health checks. And so you can see here that what is put forward by NICE was that people who are in secondary care should have physical health checks done by their mental health teams if they're in the team for less than 12 months or if their condition hasn't stabilized. Okay, next slide, please, Gracie. As Helen, I think, set out really nicely, the Trust really wanted to have a better understanding of what the barriers were that were impacting on how staff, service users and carers experience that physical health checks and physical health care, so that the Trust could understand how it could be done better. So we were commissioned to conduct a service evaluation to find out what people's experiences were, what was happening, and to produce a set of recommendations. Next slide, please. Okay, so the aims of the service evaluation was to gather a wide range of staff perspectives. We didn't do any comparisons between groups or teams. We wanted a kind of overall kind of sense of staff views. We had 5 aims. So what we were interested in finding out was about the approach and practice of staff towards physical health care, what physical health systems and tools that they were using, the knowledge and skills that staff had, their perceptions and attitudes towards physical health care, and really importantly, what the experiences and outcomes were of service users and carers. Okay, next slide, please. So we've got 5 stages listed here of the service evaluation. So stage 1, it was really important, we felt, that we really had a good idea of what the key staff roles were within adult community mental health teams. So we talked to staff at different levels within the Trust to get a kind of a list of these so that we could decide who it was that we wanted to speak to. Yeah, we identified the key roles within the teams. We also importantly established an expert by experience working group, which had people who were service users, people who were carers and staff members to help us to design and deliver our evaluation activities. And that group has worked with us throughout the project. Then we did the data collection itself. So we did 23 interviews, we did 8 focus groups, and we also did 8 observations, and we had a total of 50 participants. Staff mainly were interviewed, and then we did focus groups with some staff groups, and then we did a focus group with service users and a focus group of carers, and they were semi-structured, so we kind of were asking around those 5 aims, but it also gave us a chance that if there was anything interesting that came up, we could kind of follow that as well. Next slide, please. Okay, then we analysed those findings, and we used thematic analysis to do that. And then what we did was, it was really important for us that we presented those findings back to the people that had been involved to make sure that we had really covered and really kind of identified the things that were important to them. So we did that, and we did some kind of workshop sessions and asked them, you know, is what we're saying, is that kind of right? Does that kind of, you know, fit with your experience? And work with them in terms of co-developing recommendations to present back to the Trust. And then we shared the final recommendations with wider staff to identify the priorities, and that's kind of ongoing at the moment. Next slide, please. Now I'm going to hand you over to Gracie, who is going to talk you through our results and our outputs.
Thank you so much, Julie. So we felt it would be really helpful as part of this webinar to just share a little bit of what we found. On the screen here, we've got a schematic representation of the core findings, which sat, as Julie described, under our 5 main aims, which are depicted here. And you can see attached to each of those, the high level themes that sat and fell out of those. So a few key things I think we wanted to be able to share with you that we found that was of interest. The first was that in terms of the general approach and practice of staff, we recognise that people were highly motivated to address physical healthcare needs with their patients. The challenge, however, was that there was a sense of variability in how practice was being completed within different teams. And what we felt beyond that in terms of the findings was that it was generating a culture where individuals were taking on the mantle of doing more because they were committed to wanting to change the way physical healthcare was being approached. Some people were falling into roles such as championship roles because they wanted to be able to make a difference. But what we wanted to be able to kind of identify was, how do we do more of that? How do we facilitate a culture and an environment where more people can understand and be aware of what's needed and feel that they can deliver what is needed in routine practice? Some of the other things that people shared with us were that actually there are a vast variety of systems and tools and resources available to look at physical healthcare needs in practice, but actually also that can be complicated because it can be burdensome if we're collecting lots of data, but also because there may often be challenges in knowing how to manage that data, the governance around managing that data, and how do we use it in real time to be able to inform the care that we want to give and to be able to inform the patients we're supporting to be able to access the right care in a timely way. Some of the other things that we identified was actually relating to staff experience. Many had experience in individual roles as professional roles that they may have had training in nursing or other professions that they may be performing within the trust. But many said that it was challenging to know how to utilize their knowledge and skills in the best way. And in fact, that it may help to go further if we could provide additional training that could really scaffold and support their knowledge well in terms of how to provide physical health care. There was an additional part to this that was of interest, which was about roles and responsibilities. Staff said to us that actually they would like clarity about what to expect and how they can fulfill the brief in terms of what the core offer for physical health should look like, and actually how they can communicate that to service users so that they also know what to expect and when they can access that care. The final part to this, which was of interest to us, was about the fact that service users said to us they don't expect mental health providers to be providers of physical health care, but that they are interested to understand if that's the way of the future, how do they access that? And how do we provide it as mental health providers in a way that is sustainable so that we can actually deliver good quality whole person healthcare? So this was really, really interesting for us as a group. And what I want to be able to do next is show you kind of how we've consolidated some of that thinking. So we identified 4 core areas of improvement, and Helen referenced these in part, that we're now working closely together to look at these. What we felt was definitely needed as a starter for 10 was a clearer sense of that organisational vision and strategy for physical healthcare, and how can we work to embed that in such a way, translate that in such a way that staff feel confident and clear about how they can be approaching physical healthcare in practice, and how can they communicate that more clearly to their service users, carers, and other organisations that they may be working with, such as primary care. We talked a bit as well about this idea of policy and governance. So how do we actually look at what's required? How do we meet the national targets? How do we look at that in terms of how that translates into practice within the trust? And what are the responsibilities of the organisation and its staff? So this was definitely an area that we felt we could look further at and help the trust to be able to evolve thinking around. In addition, we talked a bit about training. So for us, there was an idea about evolving this with more specific and generic competencies that could support staff in real time, and additional support for managers and leaders to be able to help them to look at what competency might be needed and how they can help staff to develop their knowledge and skills in routine practice. And very finally, this idea about streamlining thinking. So how can we streamline processes and systems so that they actually work in the way we need them to, so that the very basic checks that need to be completed can be done in such a way that actually staff feel equipped to know what to do next when they've completed those checks, and we get the right care at the right time to our service users. So a few other additional parts to this, I suppose, to pick up Helen's point, which is part of our approach within the IMPHS team was about going further than just completing this evaluation. We wanted actually to be able to use it in a way that we could help the trust to rapidly adopt and integrate our findings to help inform policy, strategy, and things you want to change together. So we've done a lot of work to be able to present back the findings to those people that were involved in the original evaluation, but we've worked very closely with Helen and other colleagues within the trust to think about how do we evolve that thinking further. So we've been working together to develop a series of kind of strategic recommendations, and we've been thinking about how we can evolve that into change ideas by working together to deliver a series of workshops where we present back those ideas with people that we know are going to be working in the trust and ultimately delivering on those in future. So this has been a real process of co-development, and I think it's really strengthened our approach overall because of that approach that we've delivered all together. So a few things to say about kind of what we're thinking with this work and how it can go beyond this initial evaluation. We know, of course, that secondary care services have a role to play in how we look at physical health care for adults with serious mental illness. And we recognise, of course, that we have some way to go. So part of doing this webinar is really to help share the thinking, and we're interested to know how others are experiencing this and actually what other barriers may be in place that may be preventing this from working well. Some of the implications we've listed out here are actually part of the academic paper that we have produced that sets out in much fuller detail all of the kind of mechanisms of this work and the outputs. But a few key things of interest perhaps are that we know there are gaps in the guidance, not only that we've got a sense of what the checks should be, but actually how should they be completed, who is responsible, across primary and secondary care services, and how do we regulate that and monitor that? In terms of clinical practice, there is something definitely about responsibilities and the expectations that are set out about how we deliver that and how we support staff to be able to communicate and provide the right care. And in terms of further research, for us, this is a point of real interest. We do think that the findings here may have some generalizability. We anticipate that other trusts may be experiencing similar things, or other community mental health teams may be experiencing similar things. And for us, we're interested to understand where the commonalities may lie, and actually if there are further gaps that we haven't yet identified or addressed, largely because the important thing for us is about achieving parity in how we deliver physical health care. So a few things that will fall out of this work. We've mentioned there's insights, of course, to how we've actually delivered this and the strategic recommendations. But ongoing work now is about how we can develop a physical health framework that can build beyond these recommendations, that we can use to develop and sustain how we deliver physical health care within community mental health teams. This work is evolving, and we've got Rupi as well, who's going to be joining us shortly, who will talk a bit more about how we are thinking about this on a wider stage beyond just our work at SLaM. We also have, of course, the publication, as I mentioned, and we'll share that in the chat in just a moment if you're interested in seeing the fuller paper. Very finally, two things I'd like to just say is that this evaluation for us has been significant because we've been able to work so closely with the trust to be able to really listen to what is needed and to be able to work collaboratively to evolve that thinking and develop ideas, solutions together, and to kind of think forward, how do we continue to sustain that approach? Some of the key learning has been not only having a diverse team with clinicians, academics, project managers, and experts by experience, but being aware of who our stakeholders are and utilizing that network in such a way where we can lean on each other, learn from each other, and share best practice. But also the other final point about translating what we're doing. For us, it's about so much more than just doing the research or the evaluation. It's about how do we really help others to hear what we've done and to share it in real time. And I suppose to say, because we want to make an impact, right? I think we're ultimately here because we want to make a difference to the lives of service users. And for us, this work has really enabled us to be able to have that conversation and generate a community of practice approach to think about this, of which you being here today is a real representation of that. So thank you for being part of this. And we're keen to continue seeking out opportunities to talk more. So if you're interested in this work and want to build on it with us, please do get in touch. I've put our generic inbox there on the screen so you can see it. But we're just desperately keen to know who's interested and how we can share more of this work. I think that's me, Ray. I'm going to hand that back now to you. Thanks so much.
Thanks, Gracie, and thank you, Dr. Julie. Yeah, great to hear from you, and so tricky, I know, to fit all of that work into 15 minutes. But we do have quick Q&A at the end, so guys, please, if you've got any questions, pop them in the chat and we'll come back to them later. Now, though, I'd like to hand over to our experts. So part of the IMPHS model has been to work with service user, carer and clinical experts on everything pretty much that we've done. So I'd now like to invite Greta and John and Leah to talk to you about the experience of working on this project. Hopefully everybody is around.
Yeah, absolutely. So I should, how about, because Leah, we've prepared to speak, but Greta, are you on? Would you like to talk first?
Hi, yep. Hi everyone. Yeah. So my name is Greta. I'm an expert by experience, and I've been working with Gracie, with the organisation, for almost a year now. I'm a service user with long-term complex mental illness for over 25 years, and I've also got complex health. And this project is really, really good because it's looking at the new body of work that the NHS is doing, quite rightly and well overdue, of looking at the whole person holistically, their physical and their mental health. So a little bit of personal story. I suffer from sleep apnea, which is caused in part by my complex PTSD. But for years and years, I was a medical anomaly. I can never say that word. And they did not know why, what, where, how. And so the result was I was not given any treatment. And recently, with this new piece of work, the treatment I've been receiving at King's Hospital for my sleep apnea, the doctors in the lung and heart department have been looking at my complex PTSD, and I've been given a completely different approach. And ultimately now I'm much healthier because they've sort of understood the complexity when people have dual diagnosis. And I just want to say to all the professionals here today, like, please, 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 whatever your department is, you are looking at the whole person, the whole body, and mental health is to do with the brain, and the brain is the biggest organ. There is no way that any physical illness cannot be affected by any mental health illness. And it's just really, really important that people like myself, I'm included today in the conversation, I'm listened to, I'm asked, you know, I've got this really fancy title of expert by experience, but ultimately that is what I am. I am the author of my own story. I'm the person who is best able to explain when cases and patients present before you who are complex, who are nuanced, you know. There is so many things that are really important to consider when you are speaking to patients. Patients such as myself who have complex PTSD will find any medical assessments really highly stressful and may not answer questions you give them correctly or with the whole story. And then you are held back to do your job. So it's just so important that you really consider the patient as a whole and just listen to them, but really, really do everything you can to help them to feel safe, to help them to feel heard, and to involve them in all your questioning and decision making. And then it's going to be a much more successful outcome. I think that's everything. Thank you, John.
Oh, thank you so much, Greta. I thought it was really excellent, and something that really resonates from what you said, I think, is this division between physical and mental health care, and actually it is the whole person that's important, and I'm really glad that you shared that. So as part of this project, Leah and I are two of the junior doctors who have joined to act as, I mean, we've been given the title as experts. I wouldn't hold myself to be that at all. And we just wanted to talk a little bit about why we joined this project and also what we got out of it. Leah, are you online?
Hello.
Hiya.
Thanks for that, John, and thank you very much for sharing your story, Greta. Like John said, him and I are junior doctors, and we've both got lots of experience working in the community mental health teams around SLaM. And I just wanted to say a little bit about why we got involved with the project. And John and I were both actually signed up for it as soon as we got emails out for it asking for some junior doctor assistants. And we're both really passionate about our patients getting the absolute best care they can. And as people have already said before me this afternoon, this includes both their physical care, their physical health, and also their mental health. And as we know, that our patients have really big physical healthcare needs, much higher than the general population, and that we need to really tackle this and work harder to make sure the outcomes are better than they are. From our experience as actually working in these community health teams, we're all kind of aware there are standards, but we felt that these weren't super clear, and there was lots of variability as to what different teams provide. It's really variable on the kind of patient you're working with, but also the team, just who by chance you happen to be working with. And anecdotally, we'd come across a lot of staff that are sometimes hesitant in engaging in physical health care because they're not sure if it's their remit, if it's their role, or if it's the GP's role, or who really needs to take ownership of it. And also because we all have a lot of variation in our experience level. So those are some of the reasons why the two of us got involved. And I think John now was going to say a few words about what we learned.
Thank you so much, Leah. So I mean, it's been an absolute pleasure to be part of the IMPHS project, and it's a first for me to be part of something that's well put together and, like, a well-funded and coherent project. And I'm really grateful to the really hard work that everyone has put into this. It's also allowed us to be exposed to conversations with stakeholders that to a depth that we don't normally get, I think, in routine clinical care, and it certainly challenged some of my preconceptions. Something that's really struck me is that staff, patients and carers do really care about physical healthcare, about good physical healthcare, physical health outcomes. But I think in routine practice, this can sometimes get lost, and I accept now that some team members can feel excluded from the conversation. And sometimes I think that can be due to, own arrogance, for instance, within particular staff groups. And we need to be aware of that. And I think what this project has highlighted, that it's so important to have an open dialogue, coherent messaging, and user-friendly systems that work across teams and across trusts. Something else that has come out from what we've seen and kind of struck me was that we're not really ensuring our patients are well informed about our role in physical healthcare, and this would very reasonably cause anxiety. Also, just understanding the limits of our roles and making sure that is clarified across the board so that we are all delivering coherent care. As doctors, we do regularly get involved in kind of quality improvement projects, and my experience has been, I think they're really good, but they often are quite small and tend to be on the local level. And to be honest with you, the change is often not sustained. And something else that has come across from this work is that staff can become quite fatigued with constant change, which isn't coherent. And I just find to say it's been absolute delight to be part of such a large, well-organized project, which does give a coherent vision and does kind of communicate this up at the strategic level. And I take on board now that sometimes that is what's needed. So very grateful for our participation in this, and thank you for allowing us to speak today.
Thank you, John, Leah and Greta, for really honest accounts of your involvement and your experience. Really, really good to hear. I move on now to our next two speakers, so Omar and Rupi, to give from their perspective in the kind of the local and the wider context, where they think the implications for this piece of work land in terms of clinical practice and policy. And we'll go to Omar first.
Thanks, Ray. Hopefully you guys can hear me. I want to say firstly, thank you guys at IMPHS for completing this evaluation and inviting me over to be one of the speakers this afternoon. I'm actually quite proud of that. I'll endeavour to keep it brief because I think we have some time to catch up on. Secondly, I also want to thank the audience for taking the time out to attend today as well. So firstly, my name is Omar. I'm clinical service lead for the Health Check Liaison Project, and before that I was the SLaM physical health specialist nurse. So I've kind of sung physical healthcare for the last 3 years now and proudly done that as well. I think one of the things I want to take this opportunity to do is to plug the role that, that I've been leading on for the last 1.5 years now. So I lead a team, the Health Check Liaison Project, and their sole focus is to support our service users with serious mental illness to have their annual physical health screen. Now, what Gracie mentioned earlier on was like, what is physical healthcare? That my team focuses on the 6 core metrics. And I'm sure we'll find out more about those things as these workshops go ahead and these webinars go ahead. They're a great team, and they, like me, also live and breathe physical healthcare and making sure that our patients that are hard to reach and those that have the worst physical health outcomes against the general population are having access to physical health checks and the associated interventions. I guess to get back to the point that I've been brought here to speak about, so one of the first things I wanted to speak about from this evaluation is that there was a clear motivation from our teams on the ground to make improvements for our patients' physical health care. And it's great to see that in and amongst resource difficulties we might be experiencing on the back of a pandemic, and you know, we still continue to offer our patients the best care that we can. One of the other items I also wanted to pick out from this piece of work was that there was a huge willingness to share the thoughts and feelings with our IMPHS colleagues, which is a great stepping stone in order for us to find out what it is that is required from our service users and from our staff to make improvements in this particular area. So going back to the implications of this piece of work, I mean from the top, I think it's a great way to catalyze change. We have a document here that we all have access to that gives the thoughts and feelings of those that use our services, and then using this to put some action against some of these needs. I mean, it was mentioned earlier on that we will have some workshops starting from next month. I believe it's the 10th of March. And this is an example from the trust that we are going to use these opportunities to confirm roles and responsibilities. And this will be an opportunity for us to go on an ongoing journey to support our patients and staff with building knowledge, skills, and behaviours, especially around physical healthcare. As my esteemed colleagues mentioned earlier on, our patients in SLaM with serious mental illness have some of the worst physical health outcomes compared to the general population, and often from preventable disease. And this is one of the main reasons why we did this piece of work, and this is one of the main reasons why I also have stuck to physical health care within a mental health setting for the last few years. I think some of the key learning I want to take away from this piece is that it's going to be a journey, and I want us to use this as a catalyst for improvement. And I will endeavour, and I'm going to say this here, that I will make sure that we are using the recommendations from this IMPHS project to catalyse improvements for our patients with SMI. I was going to end this with a war cry, but I think I might save it to the end as part of the Q&A. And Rupi, I don't want to take over too much time in our segment for you also, but my last words are, let's continue to go into this journey. It's going to be a learning curve, and I also want us to do some of the hand-holding that's required to get to our own goal, where our clinicians do feel that they know exactly what they're meant to be doing, they know what their roles and responsibilities are. And then the goal is that we have a patient group that do not have a 15 to 20 year mortality gap compared to the general population. Thank you very much, and I'll pass over to Rupi.
Thanks very much, Omar. And hi, everyone. So as it says on the slide, my name's Rupi. I'm the Director for Mental Health and Children and Young People Services within the South East London Integrated Care Board. And we work with all of our system partners across South East London to support kind of system transformation and the delivery of our kind of strategic priorities to really improve the outcomes for our residents. And kind of, I guess, similar to other systems across the country in England, South East London has been on a significant transformation journey with regards to community mental health services. And as part of that, we want to make sure we provide good physical health care for the people who are being supported through our community mental health teams. We've worked quite hard over the last sort of couple of years to make sure that across all 6 boroughs in South East London, and they are served by 2 different mental health trusts. So the South London and Maudsley serve the boroughs of Lambeth, Lewisham and Southwark, and Oxley's NHS Foundation Trust serve the boroughs of Bexley, Bromley and Greenwich. And one of the things that we wanted to make sure through the transformation programme is that no resident in South East London, regardless of where they live, has a different access to treatment or has a different outcome. And so parity across our 6 boroughs and in that equality and equity and access to services is a real kind of key theme for us. So from this work, I guess, as Omar said, one of the great things that we've taken from this work is the appetite and the willingness and the want and desire from our CMHTs, from our community mental health teams, to really make a difference to their service users' physical health, as well as being able to support them with their mental health needs, actually being able to support them with their physical health needs as well. And that really comes through. So what are we going to do with this particular work in South East London? So this provides us with an opportunity to think about how we better support our staff that work in our community mental health teams to then enable to them to better support the service users that they're working with and supporting. So we're looking to see how we can replicate or create a framework that forms part of our core offer. And a core offer is a word that we use to basically say a minimum standard of service delivery across South East London. So we're looking to develop a framework for physical health needs that would help the training and development of staff who work in our community mental health teams to then provide good physical health care as part of their checks. And part of that will be about training, part of it will be about people understanding roles and responsibilities as has come out in the study, in this findings, but also it will be about signposting and better integration with physical health services, so we can really tailor services to meet the needs of our population and understand those better, particularly for our population with severe mental illness. So we're looking to develop our framework, and I think the learning here for others and for other ICBs, other ICSs and other mental health trusts is very much about being clear on the role of community mental health teams and how they have a role in supporting the physical health. I think we very often segment physical and mental health, and we do that for lots of different reasons, I think, but what we forget is at the heart of there is a person, and people are whole people and they have holistic needs, and we need to think about those better. So it gives us a real opportunity to try and bridge that gap. And as Omar said, what we really want to do is make sure that we don't have that 15 to 20 year mortality gap for our service users. We really want to improve the population outcomes for our residents in South East London.
Thank you, Omar, and thank you, Rupi, for speaking there. Great to hear from both of you, and it's coming through in the chat as well, about looking at the whole person, not segmenting, taking the mind and body approach to care. Really, really important. Next slide, please, Gracie. So at this point, we're now moving into our Q&A session, and some of the speakers that have spoken in the session are now going to be available. So if you're able to turn your cameras on, guys, so that if people want to ask questions, then they can do. I'll just have a quick look in the chat as well to see if there's any questions that I can ask straight off. So first one from Chris Bonstall, working within the Cancer Alliance and have an interest in people with SMI, how physical health is assessed for signs and symptoms, access to screening service and general early detection. Was there disease specific work done in your project? I mean, I can answer that. Just to check, are you talking about this particular project, Chris, the CMHT work or IMPHS in general?
Hi, you hear me?
Yes.
Yeah,
Hiya.
I suppose I saw an early slide showing some of the variation between the general health, the general health of the public, and then against people with SMI. I think that's what the slide was indicating. And then by disease group, I didn't note cancer on there, and I wondered if that was a kind of something that's being looked at in particular, or is it kind of a general approach to all health?
Okay, thank you. Julie, you were nodding your head, so you probably have an answer prepared.
Yeah, I think cancer was on there actually, Chris, and actually it was one of the ones where there didn't seem to be a big difference between people with SMI and the general population. But just to say that some of the work that has been happening within IMPHS, not in part of this project, was looking at the sort of 2-week cancer pathway and how that can be improved for people with SMI. So I think we take a very general approach in that we look at kind of physical health overall, but I think we've also been involved in projects where we're looking at particular disease specific areas. So obesity is going to be one of the areas that we're hoping to look at kind of going forward from this. And as I said, there was some work done that, Ray, you may know a bit more about than me on the 2-week cancer pathway.
Yes, yeah. So yeah, I did some work, and Omar as well is definitely somebody to get in contact with, because I think from the central point of view and the trust, and also from a Pan London level as well now, cancer is got a bit of a lens. But yeah, the cancer pathways became available for different organisations. It was no longer just GPs that could kind of apply. So we've essentially put the pathway in place, or put the referral forms in place. But it's a developing piece of work. Omar.
Just really quickly, Chris, I'm going to be leading on a project with the Pan Londonese network for SMI and cancer. It'd be great to catch up with you separately about this, because I'm co-chairing that section, and it'd be great to pick this up offline.
Yeah, that'd be fantastic. There is evidence in certain boroughs of South East London, deaths, premature deaths due to cancer are linked to people with SMI within certain boroughs. Definitely, there's fingertips data on there, and there's clear evidence that they are, say, less likely to turn up to screening and stuff like that. There's evidence from primary care there as well. So we've got data, but there definitely needs, in my view, there's some work to be done around there.
Thank you, Chris, and thank you for the questions. I'm just checking the chat. There's no questions coming through. Just listening to speakers, I'd like to take it back to the beginning and come to you if I can, Helen. Put you on the spot here. So obviously I've been involved in the IMPHS project, and from my own perspective, I think undertaking this piece of work, we were in a unique position to be able to do what we did, hosted by the trust, but not held by the same kind of operational challenges, constraints. And I think that helped us, I feel that helped us to build trust, working with the people that we interviewed and engaged with, and really get honest responses and get to the nub of some of the big challenges that the trust's facing. In terms of what I want to ask you is, if you didn't have us, what would have been the backup plan? And from the perspective of people that may be listening today or listening in the future that don't have the resource of IMPHS, how would you have approached that, and where would it have left you, do you think?
Thanks, Ray. So I think it's important to be honest and transparent in that we probably wouldn't have had a backup plan, other than we would have continued with some of our hypothesis testing and maybe done some much smaller scale QI program work. But I think that still wouldn't have given us the advantage that working with yourselves has, in the sense that You are, I mean, I always find that we work very collaboratively together, and I feel very much part of the team, and hopefully you feel vice versa. But there is also that slight distance, and I think that we mustn't forget the context in which we operate, in that clinicians can sometimes feel rather beleaguered by the relentless pursuit of what are now termed in the NHS as key performance indicators, which actually are care interventions, but we disable people, I think, through the language we use. And I think that a clinician wants to feel heard, and that's completely right. Because it's in giving people that opportunity of freedom of expression and space that we get richer data. And then secondarily, I think the other unique advantage of working with yourselves is, of course, your knowledge and skills around implementation science. And I found the thinking through about how we take the recommendations forward incredibly useful, because you have held me to account, provided effective check and challenge, and also, let's hope I get this right, help me understand the CIFA framework. Have I used, I must confess though, I don't have the breakdown of the acronym, so maybe Julie can, or Ray can help there, but really taking some time to have some considered thought about how this data can be converted into some meaningful actions that people feel ownership of in totality. Again, I use the acronym of the dark room versus me sitting in a room saying, well, I've got this list of ideas and actually we'll do this, that and the other. And I like to think that I don't work like that, but you know, we make mistakes, don't we? And it's actually, yeah, it's provided that real opportunity to stop, reflect, think about the actions we're going to take next, dig a bit deeper. If it's okay, if I've got the time to give an example of that, when we've been planning our first workshop, which the IMPHS team, Gracie, have been phenomenal in assisting with, we got into this idea about shared care, because we know the NHS contract has very specific asks of us as clinicians in what we should do for our patients. And we realised that none of us knew what the shared care documents said. And actually, we thought we wouldn't be able to find out, but through sort of a process of appreciative inquiry, we got some additional rich information, which was I thought was really, really helpful, because when, you know, we certainly for me as somebody that's in a more senior position in an organisation, I think that I'm accountable to our staff and patients, not the other way around. And I have a responsibility to know and understand and see the wider picture. So I've just found it an incredibly rich and valuable process working with you guys. I'd recommend it to anybody to have an IMPHS team.
Thank you, Helen, for that. Too kind. I think as well, what I picked up on there, perhaps maybe of use for other organisations, and links back to what Omar was talking about earlier. This is a journey. You know, you won't change things overnight, but taking that time to reflect, challenge, you know, look at those key markers could be very useful solutions. We're coming to the end of the webinar, but I did want to ask one more question, and there aren't any more in the chat from what I can see. This one goes to John, if you are still around. John, we've only got, it's going to be a quick one because we've only got a minute or so left, but going back to the theme of continuing conversations and kind of building inclusivity, feeling part of something and giving that space to people where they don't usually have it. I'm aware that you're, you know, of your continued involvement in some of the legacy of this work, but is there anything else that you're doing that you could recommend to people in other workplaces, or indeed if there's anybody listening from SLaM, or if there's not anything yet, is there anything that in the future that you'll kind of take with you from your experience in this work?
Well, an on the hoof answer, and I think we're seeing it with the teaching that's going to coming up in March, is if we can mix different staff groups and you know, the ideal would be to involve patients as well in training as it stands. And this is particularly something you find when you come out of the general hospital as a doctor, because you do your early rotations there, is that none of us seem to have training. Most of our training is specific to our professional groups, and we don't work in our professional groups. We actually work in a team with lots of different professional groups and the patients and the carers. And so I wonder if they could bring some of the training into that more realistic setting, and then we could foster some more understanding between us all. There we are. I mean, that's one thought.
That's brilliant. Yeah, really making use of the MDT and building that. Yeah, brilliant. Thank you very much. I will close the Q&A there just because we are out of time, and I have a couple more slides to share. Thank you, Gracie. So, as I said at the very start, this is a webinar series. This was the fourth one that we've done, but we have 2 more left. So next week is all about Consultant Connect, which is communications platform that we've been able to use in the trust, first place in the UK to do it, to connect primary and secondary care services. And then the final webinar is about a physical health clinic. So effectively a physical health liaison service for 2 of our hospital sites. And I really welcome you back to come and hear about those. If you're not able to make it, then we will post the videos online. We now have a learning report as well, and there's a QR code on the screen which we will hold there for 30 seconds. So if people want to fumble with the phones, if not, we can send this link out. But this is a digital booklet of the kind of the core projects that IMPHS has undertaken over the last few years. And the final slide, keep in touch. A lot of what we've done has been about building relationships, networks, and you know, communication, and you've heard about that in today's webinar as well. So IMPHS has been delivered as part of the King's Health Partners Mind and Body programme. We're still going to be around in some shape or form as IMPHS to take forward you know, work that's come out of the last few years, but also hopefully tackle some new challenges as well. The Mind and Body programme is always around though, so please do visit and take a look at some of the other stuff that is going on. And just checking the chat one last time before I close. Just one last comment, and great final words to end on. Thank you for those, Omar. Final words to all would be, don't underestimate the power of consistency and will. So thank you very much. Hope to see you soon. Goodbye.